Morning, thank you for having me here. It's a real pleasure to be sharing the podium with RJ and my colleagues Brian and Robin here. Many, many thanks to Alvi for inviting me for this particular event. When I got the topic, I thought Albie had a fine sense of humor in, he chose the title, which was basically, RJ and Albie put together the suggestion as the evidence for neoadjuvant chemotherapy, because clearly the evidence in rare diseases is often quite weak and often non-existent, as you will find. So we try to find some direction, some degree of reason in this very dark room to find our way to managing these very difficult cases. And I'd like to kind of put up a proposition to utilize chemotherapy in this setting and how that might be beneficial in the overall care of the patient. So these are my disclosures, but nothing that particularly impacts on this particular lecture. So I wanted to say a few words about the importance of rapid diagnoses, some nuances associated with establishing diagnosis, talk about the rationale of why do we even bother to give chemotherapy to these patients, shouldn't they just go to the OR directly, and would like to talk a little bit about the proposed treatment algorithm that we use in Houston for taking care of these patients, and discuss a couple of regimens that we typically use for neoadjuvant chemotherapy at our center. So I think the key thing about diagnosis is the rapidity with which you can actually get this done. It's very, very critical to establish diagnosis quickly and not waste your time waiting for things that are not useful in establishing diagnosis. One of the key things that in this particular space is pericardial effusion. A lot of these patients will have fluid, which seems like a very low-hanging fruit to establish diagnoses. I've been there at MD Anderson for about 12 years. After the first 3 years, I couldn't recall the one single time I was able to establish diagnosis with pericardiocentesis. So we did a study of all of the patients who have had pericardiocentesis, and over 100 pericardiocentesis, and the number of cases that got actually the diagnosis established with pericardiocentesis was 0. So this is totally useless. So it's something important to know. So when you get a case with a tumor mass and fluid around the heart, and you're thinking, oh, let me get some fluid and run it for cytology, think again. Save that day, talk to your cardiovascular surgeon on that day to try to get tissue diagnosis, because this fluid is not going to get you anything other than set you back by a day or two, which matters in many of these cases. So sarcomas are more common on the right side of the heart, and multifocal involvement is extraordinarily rare. If multifocal involvement is present, it's quite likely that it's some other process rather than sarcomas. Histopathological diagnosis, and this is another thing. In centers like here, it's probably not that much of an issue where the importance of establishing diagnosis is well understood. But in many hospitals, I hear the whole line about, why does it matter what it is? You know it's a tumor. Why don't you go ahead and treat it? We'll take the tumor out, and at that time, we'll establish diagnosis. It's an extremely dangerous, thin ice move there, because you have no idea of the prognosis. You don't know how to pick the regimens appropriately, how to plan it, and most importantly, prognosticate it properly to the patient so that they can make appropriate decisions as to which direction to take. So it's very, very critical to establish diagnosis, and a sound histopathological diagnosis by a pathologist familiar in this territory is very critical. It's very, very critical to involve the surgeon early. I mean, none of these cases, even the ones where you think the metastatic disease is not florid, but oligometastatic disease, I always make sure that Dr. Reardon, who partners with us almost on every case, sees the case up front. just took care of a girl who has been on chemotherapy with adriamycin, went into heart failure, ejection fraction of 35, then was on Taxol for an extended period of time, and eventually no biopsy was done, which was crazy because I acquired the patient about 9 months later, CRS consult. The first thing I did was send a patient to Dr. Reardon to get some tissue. It was actually a liposarcoma where Taxol has actually no activity at all, which the patient was just on. It was a slow-growing liposarcoma, so they thought it is a responding cardiac either spindle cell or an angiosarcoma, which does not necessarily which progresses rapidly, but if it is progressing slowly, then it must be working, was the logic. So the patient was on Taxol and considered responding to Taxol, while actually what it was a slower growing liposarcoma that Taxol was doing nothing other than making her nails fall off and give her peripheral neuropathy. So very critical to establish that tissue diagnosis and involving the surgical team early. Staging is also another area that we often forget about. Very critical to get a accurate volumetric estimate of the tumor at the primary site, and also look for sites of metastases. We use functional imaging a lot because we like to look at response quite rapidly. Functional imaging allows you to check for responses early and put a call out to the surgeon to make sure that it's on the schedule if the patient is not responding, to push to surgery relatively early. Brain metastasis is another area. About 20% of patients will have brain metastasis. That's 1 in 5 patients. So you put them on chemo, their tumor will first get unstable and bleed, and the patient will come back to the ER seizing, which people may be labeling as late ifosfamide toxicity. It's not ifosfamide neurotoxicity. It's basically a CNS bleed. It's always a good idea to screen that off up front and make sure there's nothing in the brain that requires initial radiation approach before you move forwards. So this histologic subtypes, it's a complicated slide. The reason I had to kind of leave it as is because different studies have looked at the different histologic subtypes in their own populations, and you'll see a huge amount of variability for example, if you look at intimal sarcoma, in some of the series, for like this one right here, it's about 42%, which is the only one where intimal sarcoma, apparently, the title of that particular paper specifically was intimal sarcoma is the most common sarcoma in the heart, and the paper is out there. I don't have any dispute with the claim that is being made, but you have to be very careful when making such claims. I didn't review this paper, but in most of the series, angiosarcomas generally tend to lift up to the top, but referral bias and the kind of patients you take care of can have a huge impact on it. And also your pathologist, the way they are calling the diagnosis, can make a huge difference. But these are some of the histologies that usually emerge, and all of them have treatment-related connotations in terms of how they respond to treatment, and therefore treatment planning decisions and choice of regimens will change depending upon what it is. So why should we bother with neoadjuvant systemic therapy? The fundamental reason why cardiac tumors, we believe, should undergo neoadjuvant chemotherapy is because they tend to be highly metastatic. These patients can die from primary disease in their heart, but most often it's metastatic disease that takes them down. So in a systemic disease, managing it with local strategies alone is often inadequate, and therefore we make an attempt to take drugs that usually work in the metastatic setting for these particular patients and push them into the neoadjuvant setting to try to see if we can reduce the tumor. Of course, the cardiac location facilitates dissemination because you got an organ beating 80, 90 times a minute, agitating the tumor and dispersing the cells all over the place. if you look at median survival of patients who undergo resection with curative intent, this is non-metastatic patients. So there isn't another tumor in all of oncology where localized disease has such poor survival. In patients with curable localized tumors, the median survival is less than a couple of years. We all have our stories of our long-term surviving patients, but when you look at the bulk of patients, the survival is still quite dismal. And therefore, there's an acute need for systemic therapy options that can be helpful in improving the survival in these particular patients. Again, to put a plug in there that metastatic disease is more common than you think. Most often you think it's localized because you haven't looked hard enough. And make sure that the development of metastatic disease is very critical, identifying it before putting the patient through a tremendous risk of cardiac surgery. So I'd also like to point out that it is not really chemotherapy that actually predicts the survival of the patient. So if that were to be the case, that would be the evidence I would put up and I'd be done in 5 minutes. So it's very interesting. It's actually the margin status that actually is the best predictor of survival. Now, this can often be read as, well, surgery is the only thing that matters. Of course, surgery is the quintessential part of the management, but achieving a negative margin is a multi-layer process which may include a successful and good response to chemotherapy in order to make the tumor into a manageable, resectable shape. In our margin-positive cases, the survival is dismal. We get a median survival that's in like 10 months or so, as opposed to, which is very close to or same as metastatic disease survival. So getting the negative margins require pre-therapy, and that's a very critical thing to kind of keep in mind. And of course, the systemic therapy, while it improves the likelihood of getting a negative margin, you also need to keep in mind that the response to chemotherapy also has an impact. So I just sorted these histologic subtypes on the basis of their median survival. Actually, the most aggressive disease is up on top, but it also is way more chemo sensitive. So it's interesting that the aggressive things actually can have good survival, and which is only possible if you are using the systemic therapy. And the histologies where chemotherapy doesn't work all that well still continues to have pretty dismal prognosis and survival. So this is probably closer to what Albie and RJ were wondering about, the evidence piece of it. So this particular table shows, classifies the patients on the basis of patients who have received absolutely no neoadjuvant or adjuvant chemotherapy, and slowly grading up to both adjuvant and neoadjuvant chemotherapy. So as you go down the list, as you add more and more chemotherapy into the mix, you'll see that the median survival has a trend towards getting longer, from 3 months to 27 months. Also keep in mind, if a patient is not getting any neoadjuvant or adjuvant therapy, they are also probably super sick to receive therapy. So there is a bias that could come in from that angle in there. But if you compare these two subsets where you don't give any neoadjuvant or adjuvant therapy, or you do both of it, you can see that there's a substantial increase in survival. Also keeping in mind the number of cases we are using in order to make these sort of decisions is like 18 cases. We can do better than this, and which is where RJ's idea of an international collaborative to put data together so that we can look at this in larger numbers across the globe would be very, very beneficial in making these sort of decisions. So how do we treat these patients in our neck of the woods? So we confirm pathology, and that is the first step in managing these patients. And if they are hemodynamically stable, which the right-sided tumors often are, as opposed to the left-sided ones, they will go to receiving neoadjuvant chemotherapy with imaging, which preferably, if you can pull it off, functional imaging is preferred, because it gives you not only just structural data of how big the tumor is, but also tells you about glucose consumption or any other parameter you want to monitor. We give chemotherapy, and we give every 6 weeks the patient is imaged, just to make sure that the response is there. If the patient is not having a response, you immediately contact the surgeon to see if the patient should go to surgery at that time or change the regimen and try it again. If the patient is having a response, the evaluation again involves the surgeon to see, do you think you can get a margin negative resection? And at the point where it's small enough to really resect out, you push the patient to getting a surgical intervention. And that's the approach that we use. So in the absence of neoadjuvant chemotherapy, only about 33% of our right heart sarcomas have a R0 resection. So anything that is not R0, so majority of the cases we would consider them a failure even before we took off, because a margin positive resection does very little for these patients. It recurs and they die at the same rate as if they had metastatic disease. So tumors without extracardiac extension are often considered for resection after the chemotherapy, and limited metastatic disease. And this is a confusing area where you do need a little bit of experience to figure out what constitutes an unresectable case and what doesn't. If you have an excellent response to chemotherapy, one can actually make a case for considering a limited metastatic disease that has disappeared on chemotherapy still to be considered for surgery. Keep in mind that in angiosarcomas and in patients with liver metastases, this is an exceedingly difficult proposition to win. But if you have other strategies like IO, pembrolizumab, or immunotherapy that you can follow up your surgery with, certainly worth the effort of trying to get that done. So I've got a few slides about the regimens that we use. Most of the sarcoma aficionados in the crowd are probably very familiar with them. But I do want to make a few points about the choice of agents. Here's some of the key histologies that we typically see in the cardiac location. But one of the things you'll notice that adriamycin and ifosfamide, the chemotherapy that you just heard in the case presentation earlier, figures up top on the list for most of these particular histologic subtypes and are readily used, and appropriately so. The response, however, is quite varied. For example, intimal sarcomas and angiosarcomas respond really well to Adria ifosfamide, while the response to Adria in leiomyosarcomas is mediocre at best. It's not really all that very good. It's still a very good drug in the list of agents under leiomyosarcoma, but the activity is a whole lot less, and the volume reduction you will get by giving the chemotherapy is a whole lot less. That's important for you to understand, because if you're hoping that a leiomyosarcoma will have a 90% reduction and make RJ's life easier, you would be wrong, because it doesn't happen. So you may want to know that fact before you push the patient to chemotherapy, while the situation is completely different in angios, where you will, most cases, will have a very dramatic response in that setting. So there's also these three slides of some patients with metastatic disease. I put it in there because people always tell me, oh, chemo doesn't work in sarcomas, sort of a concept. It's not entirely true in angiosarcomas. As a patient, the panel on the right is diffuse innumerable lung metastases that clear up within a matter of 6 weeks with adequate therapy. Some of the haziness that you see on the panel on the right is actually bleeding from the mass. which can often look pretty dramatic, but it'll clear up very quickly. So all of it is not disappearance, like CR in the lung. It's really the bleeding disappears once you treat with chemotherapy. This is another case where adrian ifosfamide combinations can be quite helpful in volume reduction. And even in patients with, this patient passed away, however, you can have quite dramatic and durable responses lasting a long time with chemotherapy. Certainly not within the space of neoadjuvant therapy, but it would be incorrect to say that systemic chemotherapy agents lack activity in this group of diseases. There's actually dramatic activity, not in a few cases that I save for presentations, but in most cases that we treat, you will see quite a bit of activity. So these are the doses that we use, and they are definitely disputable. My colleagues in other centers will tell you that there are lower doses of this that can be used in practice. We generally tend to go with higher doses in this particular population because we want to effect a response to help facilitate a better or a complete resection, which is supported by all of the neoadjuvant and adjuvant trials that have actually, even the ones which have shown no improvement in survival, where chemo versus no chemo, have really shown that when you use combination chemotherapy, the response rates are much more robust with the combination. And since margin negative resection is the goal here, response rate is important because it actually causes the tumors to shrink, and therefore a useful strategy moving forwards. So I put these particular studies together just to give you a sense of the increase in median survival that goes on as doses of chemotherapy are increasing down. You'll see that from 50 milligram per meter squared, like a breast cancer kind of dose, moving up all the way to the 75, you're actually increasing your response rate considerably and also your CR rates as you go down the list. So each of these studies are in different institutions across the globe using different doses, which have been progressively increasing over time, and you will see that there is a dose-response relationship that you'll see, which is something you do want to engineer. This is the regimen that we use. Dr. Patel works at our center and is the vice chair, so I just want to call that out because it is our standard, because we think it works, and also my boss tells me to do that. There are the responses to adriamycin and ifosfamide, and we talked about is dependent on different histologies. So if there are certain histologies that AI works better for and than others, and that's kind of important to keep in mind while you're planning therapy. Gem and docetaxel is another combination, very easily tolerated, easy to give. Would recommend using functional imaging when you're giving AI so that if it is not working, you'll pick it up early and switch the regimen out before the patient actually starts to progress and volumetrically complicates life for your surgeon. We also recommend that we use the doxorubicin-based regimen first. The reason why we recommend that is that the activity that we see for doxorubicin and ifosfamide is more effectively demonstrated in the first-line setting than in the second-line setting. And I'm not entirely sure why this is the case. I think what's happening is that this is a rapidly proliferating tumor, and when you start therapy with like a metronomic regimen like gem or docetaxel that's given weekly, or Taxol that is given weekly, you alter the dynamics in the tumor itself to such a way that a regimen like adrian ifosfamide, which is really a big gun once every 3 weeks, ceases to work because the tumor learns to survive the metronomic chemotherapy by reducing the fraction of cells that are in the dividing pool. And if you take those tumors and stick them into the AI setting, it may not work as well. So we don't use AI in the second line setting. We prefer to use it first line, and that's why we use that regimen first. Gemtax, on the other hand, there isn't much of a difference between these two particular settings, so we kind of stick with that. And the duration, how long to give neoadjuvant therapy, do not extend therapy for more than 3 or 4 months, because the median time to progression with any of these agents is always less than 4 months. This is not our data, it's from New York, and you'll see that the median progression-free survival for this condition is only 4 months. So even in the patients who are having great responses, don't get greedy, it will not last. So you want to treat them and get out, and let your surgeon in to operate so that you cash in on the benefits that you have engineered, because angiosarcoma is really good at showing you a great response. You get greedy, and in one scan you will actually make the tumor bigger than you originally diagnosed it with, and all of the benefit disappears very quickly. So to summarize, establishing a pathological diagnosis is very critical. Thorough staging is required before you go in to consider treatment planning in any given case, because it does affect it. Margin negative resection is so incredibly important, and neoadjuvant therapy, we believe, aids in reducing the size of the tumor and facilitating this R0 resection. And a combination of adriamycin and ifosfamide is what we've traditionally used, and our data also supports that using that up front actually has been helpful, hopefully with the functional imaging that is available. In many of the studies that I've shown you, they've rarely ever used functional imaging. So having PET-CTs is a tremendous advantage, because it actually tells you if you are having a sizable response or not up front. So our intent to treat analysis has a big, huge problem, because everybody who got chemo compared to everybody who didn't get chemo isn't the right fulcrum to compare against. You should really compare the ones that have had a real good response on functional imaging with those that didn't, because that's the real comparator that you want. In patients who are having a dramatic improvement, which you can trace on functional imaging, do they live longer compared to those who don't? That's the real comparison that one has to look at to kind of keep that in mind. And doses, we believe that dose is very critical in establishing, at least in adriamycin and ifosfamide, less so in gemcitabine and docetaxel. So, and all of these facts are disputable, and I welcome you to put trials into place so that we can start examining and proving and disproving these well thought out theories. And we know, they are always so full of holes. Thank you.